Hello, everyone. Welcome back. Now, for our next segment, Making the Business Case, we will hear from a state Medicaid plan leader on the business decisions to address social isolation and loneliness. I'm excited to welcome our speaker, Patrick Gordon, who serves as the Chief Executive Officer for Rocky Mountain Health Plans in Colorado, a United Healthcare company. Patrick has led reform efforts in the Colorado market for practice transformation, payment reform, and technology adoption to help make the healthcare system work better for everyone. We are thrilled to hear from Patrick about how Rocky Mountain Health Plan leveraged the accountable health communities model to better address the social health needs of their members. Please remember to leave any questions you might have for the speaker in the Q&A section to your right. And now, Patrick, I will turn it over to you.
Great. Good morning, everybody. And thank you all for getting together to talk about this very important topic. I very much appreciate the opportunity to share some of the work that we've done and to learn in this series. So very much appreciate the focus and dissemination of learning regarding social isolation. This is something that I think all of us find intuitively true, but there are reams of evidence underscoring the adverse impact that isolation, disconnection can have on health. And not just for older adults, I think, as we sort of think, but actually for everyone, for younger adults, and certainly for underrepresented communities experiencing other health inequities in the system. That's certainly what our work indicates and sort of demonstrates in the data we've been able to collect. And it's something that we hope that we can address effectively going forward. We'll move to our next slide. So just to kind of put our organization and our efforts into context, this is a lovely map of the state of Colorado, and this is the area in which we worked with Center for Medicare and Medicaid Innovation on a cooperative agreement for the accountable health communities model. That was a 5-year cooperative agreement, and we served as a bridge organization and basically kind of a backbone to accelerate not just the engagement of healthcare providers in screening, but the development of community-based systems for access to resources, for follow-up and loop closure on referral, and for deeper engagement in navigating the system. And so this cooperative agreement from CMS was our impetus to take this on. There were many other systems and communities around the country that did the same, I think 30 altogether. What's unique about our effort, though, is that we were really working in a largely rural and frontier system with a network of providers and community-based organizations, not really just working through one large urban health system or one major provider partner. And so we were a bit apprehensive when we took this on, but what we found was tremendous. Even though we weren't able to work with a single major provider, we were able to engage over 17 hospitals and emergency department teams, 9 separate FQHCs, 4 community mental health centers, and then over 20 private practices, pediatric, family medicine, internal medicine throughout the region on the collection of data through use of a CMS-approved screener for food insecurity, housing insecurity, transportation issues, risk for interpersonal violence, personal safety issues, and of course, social isolation. And it took us a while to build a network of partners, really to empower local health alliances and 501c organizations to really sort of lead and organize the work in their own communities. because this is a vast geographic territory, and most of it is carved up pretty decidedly by mountains and valleys. So we needed communities to really own this. We were very successful, fortunately, in getting that to happen. The other thing that I would call out is that we had tremendous provider response, even though there wasn't a central system kind of pushing this forward. And more importantly, with provider response, even though we were not offering reimbursement, direct provider reimbursement for the screening activities. We worked very hard to integrate screening into existing practice workflows and to share information efficiently through regional health information exchange. But what was very interesting and exciting is that right at the outset, we had practices and provider groups stepping forward saying, yes, we want to do this. Yes, we know that it's important to screen for social risk factors. We have concerns that if we screen, we won't have the resources available to do anything about it, but we want to make that effort together. And right at the outset, we had a pretty good network, and we also had tremendous response from community-based organizations, food pantries, shelters, other community-based organizations that shared a mission of reducing these social risk factors, but had never had an opportunity really to formally engage a healthcare system or healthcare network. And they jumped at the chance. We had over 112 different organizations across this geography sign up on day one, willing to share and update eligibility criteria for their various programs, receive data, participate in closed loop referral. And so that was very exciting. Ultimately, over 5 years, we achieved CMS's target, which was to screen over 100,000 or complete over 100,000 screens. Of those screens, about 68,000 were unique individuals. And so it gave us very rich data in terms of major drivers of health risk factors in our community. Next slide. So these are the results. Again, the distribution of the screens delivered to the 68,000 unique individuals over this period of time. And you see a pretty even distribution, actually, of all the major factors. Food is a major driver. It is, we think, very likely underreported. We think food insecurity is rampant following the impact of the pandemic. And so that is very much a central tendency. But social isolation was a major gap. You see 14% of the individuals of the unique individuals that completed our screens indicated issues with social isolation. So the very fact that we were able to connect and engage with them in healthcare settings is important because isolation means just that. It's very difficult sometimes to engage our membership or people in the community. Healthcare utilization, healthcare access creates a very important opportunity to get the needs of people in this group on the radar and put ourselves in a position to respond. So again, this is a largely rural area, so you'd think that isolation might be something as prevalent as we've seen, but we had many other learnings as well. Let's go to the next slide. So again, the thing that was striking to me personally, kind of going against the conventional wisdom, is that yes, there are several older adults, particularly in rural areas, who are affected with isolation, but our central tendency was actually younger working age adults who are isolated for a variety of reasons. They could be cultural, they could be geographic, they oftentimes correspond with mental health and substance use disorder. issues. But that was something that was really clear in our data. By and large, also, BIPOC populations were overrepresented in our data, and so it's clear that health inequity in the system, broader inequity in our culture, contributes to isolation, and it's something that we certainly will focus on for the populations in our region. Latinx, tribal communities, and several others were very much overrepresented in the data we received. I mentioned anxiety, depression, SUD. Of course, that's an issue, and I'll turn to behavioral health access in a minute. But the thing that was interesting is that, of course, isolation is predictive of other factors. So most of the people that screened positively for isolation also screened positively for food insecurity, for transportation and utility issues, for safety, and of course for housing. And so obviously, it is frequently the case that people experience adverse social determinants in multiples, and then because of that experience, develop other issues related to toxic stress and that sort of perennial state of survival. The challenges associated with the culture of poverty and dealing with poverty day to day. And so, again, looking through the lens of social isolation or looking through other lenses really brings the needs of the population into relief. Of course, rural geography and rural resource concentration are an issue. And so the needs that people are experiencing, the gaps, frankly, that we identified, but were perhaps not able to fill, were compounded by the landscape and the geography we're working with. Our responses to the screeners were I think, valuable but embryonic, right? We worked with provider partners and practice partners to do what outreach they could, certainly to make referrals for resources and to make referrals to our own team, the health plan, which could, support basic navigation, navigating program eligibility, navigating healthcare access, and just basically having a resource to talk to. Care coordination outreach is far from a sufficient response, but it did have an impact in our work and in the evaluation of our work. The data we collected also underscored the need that we had to significantly expand our behavioral health network. Roughly at the same time we initiated the cooperative agreement with CMS, we initiated a contract with the state of Colorado in which we assumed responsibility for delivering the Medicaid behavioral health benefit. And our top priority was to open our network, to encourage independent providers to participate, to provide them with resources and reimbursement and training. Again, because onboarding new provider groups in a program as complicated as Medicaid can be a challenge. But we were rapidly able to expand our network. It grew by almost 76% in the same geography over the time period of the cooperative agreement with CMS. And that put us in a position to do outreach and to engage with the members that we'd identified in need much more effectively, to make referrals much more effectively with much more timely access to services. And again, to build evidence-based programs like peer resources, both for SUD and for behavioral health, that are very impactful. Again, when they can be accessed by people in this territory. So that was another focus area. And then last but not least, of course, telehealth is central to the story. In rural areas, again, we do have broadband issues that persist, but by and large, we're successful with pairing our behavioral health and peer programs with telehealth access. And we had very rapid uptake and sustained uptake, frankly, even at this stage with the public health emergency, sustained uptake of telehealth, telebehavioral, and peer-oriented resources. We are also evaluating new technology. There are a variety of apps and tools out, and also startup programs that pair technology with human interventions. What's interesting to us is that even when it's clear to a member or a person that they're engaging with an app, or maybe they're engaging with an app with, care coordinator or some human contact on the other end, that engagement is meaningful and has a positive effect on self-reported experience with loneliness. So we hope to scale additional technology next year, so we don't lose momentum. But that was a very interesting outcome of our study. Okay, last slide. Obviously, there's a huge need for better screening, better community systems of care, more closed loop data insight around social isolation and related social risk factors. In our evaluation, we can see very significant impact on typical health utilization metrics like unnecessary emergency department utilization. We had a 41% positive impact for members who were referred to our navigation and received navigation support pursuant to our social risk factors, social isolation screening. Of course, that goes hand in hand with reduced hospital admissions and readmissions. Very importantly, outreach, empowering people, acknowledging their loneliness, creating the opportunity for them to connect to peers and other programs and to providers that can support is critical to reduce stigma. And stigma, both with behavioral and substance use needs, as well as things like food, remains very high. And so one of our single biggest objectives is to promote awareness and to change the culture around isolation and self-reliance and resilience and so on to something that is more supportive and connected in the community. And then, of course, building out capacity in primary care and in the network and integrating the two as much as possible. That's something that we've worked on for years. I think it's part of the reason why we had so many willing provider partners step forward, even without a direct reimbursement model for the screening activity. And we're confident that as long as we continue to invest in primary care and behavioral health capacity and in authentically integrated services, that provider willingness and ability to screen for and respond to social risk factors will continue. So I will pause and hand it back over to you guys on the team so that we can do Q&A or whatever we need to do next.
Sounds great. Thank you so much, Patrick. Really appreciate the insights and in your leadership here. I think that what you've shown us today is some great early results on your screening strategy, as well as some of the early deployment of some of the solutions, such as your navigators. I'm wondering, I think we might only have time for one question, but I'm curious what advice you might offer other plan leaders who are looking for opportunities to address social isolation, loneliness, and connection for their members, or maybe some lessons learned from the last couple of years through this program and the successful partnerships you've been able to make with the community as well.
Well, I don't have any brilliant insights other than I think many of us on this call recognize that it's important to just start, right? So sort of resolving that endless clinical question of, well, we'd love to screen, but what if we screen and we can't respond? What will we do? Maybe it's best not to screen. That's a real clinical issue. And creating for lack of a better word, the kind of a safe space and the support with provider partners to say, look, we understand that, but we're not going to break the cycle. Kind of like behavioral health integration 10 years ago. We're not going to break this cycle unless we start the work now. And that seemed to resonate. We, of course, we had the impetus of a big federal cooperative agreement along with a mandatory CMS tool that included contemporary type screening measures, like the Prepare tool, but was different. I would encourage you guys to tap into what your providers are already using. I know that Prepare is pretty widely disseminated among federally qualified health centers. And so tapping into work that's already going on and building on clinical workflows wherever you can find a place to do that was helpful. Obviously, collecting the data is a challenge. I don't have any magic words there. Again, just work with provider partners. If it's a small number of large providers, maybe you can obtain EHR access or report layer access. In our case, we used Community Health Information Exchange, and that worked incredibly well for this use case, like it does others in rural areas where there's one network to tap into to share information rather than the effort of trying to develop point-to-point contacts, even where they're relatively few. So that was something that helped us. And I will say, even though we didn't reimburse for screening, the overall reimbursement model was important. So having something other than a fee-for-service vision for primary care and for behavioral health, I think is important. And, to the extent you can make prospective payments, value-based payments that recognize practices or providers in some kind of system that allows them to differentiate when they take challenges like this on, that can be productive. It was in our case.
Thank you so much, Patrick. The great responses all around. And I know that initial program has ended, but we're, hopefully we'll see additional opportunities to include those incentives and continue this great work. I know just before this, we heard from our friends at CMS, so definitely stay tuned on that front. I really want to thank you again, Patrick, for being here with us today. And to our audience, we hope that you will head back to the reception area for our next segment on Main Stage 1.